All right, welcome from my back porch, my lanai in Florida. I think this is probably the first time I've given a lecture from here, so I hope everybody's doing well. As Susan was nice to say, I've got two talks to give you today. One is about anemia. I am an outspoken proponent of trying to do patient blood management, and you'll certainly get that feeling by the time I'm done with this talk. And the other one is about coagulation management, another subject that I'm very passionate about. Usually I get to stand up on a podium and look out at 100 shining faces, but now I guess I can see only 4 shining faces on the video. So on the left-hand side of your picture, you see a poster for what we're calling the Gator Way lecture series, is practicing excellence in transfusion. And what I'm trying to do for the cardiac anesthesia team, surgery team, and perfusion team all together, plus ICU, at University of Florida, is to have a shared mental model. In other words, we're all going to follow the same the same group of data and make decisions off the same group of data. That doesn't mean that we have to be in lockstep and follow a protocol religiously on every last thing we do, but I would like us to at least have a background of the same types of things. So this was a talk, or part of a talk, that I presented to everybody a couple of weeks ago about anemia. So first of all, we need to define what anemia is. And in some ways, like pornography, it's I know it when I see it. But their World Health Organization definitely has definitions of anemia. And I will put it to you that anemia is a continuous variable. And it goes all the way from the very edge of normal all the way down to, say, 7 or 8 grams per deciliter. It's not uncommon for me in my operating rooms to encounter patients we're putting them to sleep that have 7.5 grams per deciliter of heme. And I am darn sure that they would do a whole lot better if we got that up prior to surgery. So we need to define it. We need to know that anemia is absolutely associated with adverse outcomes. However, anemia in itself is a disease. It's actually the outcome of many diseases, and it's the outcome of chronic inflammation. Gee, do any of our patients have chronic inflammation? I think so. I think most of mine, when they come into the operating room, have one reason or another. And unfortunately, transfusion doesn't make it better. And transfusion, I and a bunch of other people have coined this phrase, that transfusion is a therapy in search of a disease. Transfusion does not treat any given disease. As a matter of fact, the data, and I'll show it, and I've shown it over and over and over again, is that transfusion actually makes anemia worse. It doesn't make it better. It makes it worse. So the treatment is to treat the anemia prior to coming to the operating room, and that has been fought against in heart surgery for the longest period of time, because in the United States, at least, heart surgery is a drive-through event. In other words, you drive up one day, you say, I got symptoms, the next day you get cathed, or the next day you get an echo, and the next day you get surgery. So it's not been a long-term, preoperatively available situation where we can treat patients. So we need to think about which patients we could begin to put through some treatment. So what is the definition? Well, for males, it's 13 grams per deciliter, and for females, it's 12 grams per deciliter. Anything above that, you're not anemic. Anything below that, you're anemic. That's a pretty tight definition. And we've always accepted anemia as just a standard problem that our patients show up with, just like they show up with high blood pressure. But today, we would no more put somebody to sleep with uncontrolled severe hypertension or uncontrolled diabetes. And I will put it to you that in the future, we may, I hope, not put patients to sleep who are anemic, and especially profoundly anemic, if we have other options. And so to just accept that as that's the way it's always been and that's the way we should do it, I think personally is just plain bad medicine. And now it's time to do better, more complete medicine. So the World Health Organization knows a lot about anemia. The World Health Organization is responsive to literally billions of people on Earth. You and I live in the United States, which is supposed to have very advanced medical care, but really the rest of the world in some ways is more advanced in how they take care of anemia. And the World Health Organization, since 2010 and onward, has taken a very aggressive stance that patient blood management is one of the main leading roles that they can play in entire world health. And what they are after is that patient blood management is as important to sub-Saharan Africa or India or Sri Lanka or Indonesia as it is to modern day highly skilled Western United States medicine. In other words, if we save people, if we treat anemia, if we reduce transfusions, it'll all be good for everybody depending on where you live, and it may be different in different ways. And of course, there are three different standard pillars of blood management. One is obviously what you and I do in the operating rooms, what we do on bypass. Do we wrap? Do we muff? Do we ultrafiltrate? Do we, how do we do all these things? Do we, any number of other ways that we can conserve red blood cells? Obviously, what people do in the ICU makes a difference, but how we optimize our patients for red cell mass coming into the operation is the third and perhaps the strongest and the biggest thing that we can possibly do is to enhance red cell mass coming into the operation. So just to go on, the American Hospital Association has actually made it, while they're trying to improve health and improve quality, they've made it their number one quality thing for the American Hospital Association to do appropriate blood management for inpatient services. Now, I can tell you there is only one hospital in the United States. There's only one hospital in the United States that is certified as a PBM program, and that's Georgetown. There are other places that are practicing it, but they're the only place in the entire United States out of 5,700 hospitals that have spent the time and effort to go through and get certified in patient blood management. Yet, American Hospital Association says it's our number one quality improvement thing to do. So we've got a long ways to go. So how many patients are anemic? Well, I didn't put the number on here, but if you count that up, that's 34, and eventually this is going to amount to 100. So 34% of our patients, all comers, for all hospital admissions, this isn't heart surgery, this is all comers, all hospital admissions, 34% are anemic by World Health Organization definition just coming into the operating room. And we have no routine detection for that, nor routine correction before they come into the hospital. They just come in, somebody orders a CBC, oh yeah, you're anemic, oh well, so that's what you brought to us. It's your fault, you're the patient. Let's blame that on the patient, okay? So another 25% or 26% or something, we make anemic during the time we have them. This is all comers, all patients, all hospitals, and this is not just the United States. This is actually Western Europe as well. So we make another 25% anemic during the time they stay with us. So now together, and how do we do that? Well, probably the biggest way we do that is we bleed them. We bleed people in the hospital by taking routine blood tests all the time, and large amounts of blood. And you know how much blood is utilized for routine prothrombin time? Oh, about 1/100th of a cc, or I'm sorry, 10% of a cc. And so we take 2 to 5 cc's of blood, and all the rest of that just gets thrown out as waste. So we got tons of phlebotomies. And so in the hospital right now, 57% of all patients are anemic. Now, that's all comers. That's not heart surgery. In my patients, we've looked at orthopedics, we've looked at general surgery, we've looked at a number of other things. And for those non-cancer surgeries, we're seeing about 35% all comers to our hospital. But for my hospital, for heart surgery, 78.6% of patients are anemic. Wow. So almost 80%. Now, clearly at University of Florida, we do some pretty complex surgeries, and we do a lot of re-ops, and we do a lot of ruptured aortas and things that, you might expect to be anemic. But we do, a lot of typical valves and other chronic disease states. In Australia, and this is a 2017 really nice paper out of Western Australia. They took a look at all their patients coming for elective cardiac surgery, and they found that about 35% of their patients were anemic, and so a lot of those were routine CABGs, but 23% were iron deficient, 70% was anemia of chronic disease, and that's exactly the thing. All of our patients have chronic disease, and I'm going to show you reasons why chronic disease absolutely feeds into our patients being anemic more often than not. But here's one of the cool things, that almost 50% of those patients who had anemia of chronic disease would respond to iron, not oral iron, IV iron. So unfortunately, and again, a problem in this country is that both Medicare, Medicaid, and the insurance carriers make you give somebody oral iron before you can give them IV iron, unless you got some way of talking them into it. So we're pushing the rock uphill, but when has that ever stopped me before? I'm always pushing the rock uphill. So here's a very important paper, and this was, I think, in the Lancet, like in 2010 or 11. The actual citations on the next slide. But what you're looking at in that graph is that preoperative anemia absolutely affects postoperative outcomes, and this is non-cardiac surgery. Okay. So what about non-cardiac surgery? Well, if you have cardiac disease, but you're having non-cardiac surgery, the purple bar is anemia, but you're negative for the actual factor. Okay, so you don't really have so much cardiac disease. But if you have anemia and you have the positive factor, you get the orange bar in terms of, this is a combined composite, all possible morbidities. In other words, renal failure, stroke, heart attack, failure to thrive, pneumonias, etc. But if you have both of them together, anemia and that particular positive factor, it doesn't matter whether you got cancer, diabetes, obesity, CNS disease, everything anemia makes matters worse, absolutely across the board. And the key that you will read down in the lower right is that transfusion doesn't make it better. Transfusion actually makes it worse. And here's mortality. So mortality is actually worse than morbidity. So mortality for those patients who are both anemic and have any one of these other risk factors is worse. And here's the key. If you transfuse, it is 3 times worse. So just having anemia alone is bad, but for us to go and then give a blood transfusion makes it 3 times worse. So, wow. When it calls into the question, which is that we have always just assumed that we could just give them a unit of blood and they'd be fine. So here's another paper, Harry A. Shander, Matt Warner, Linda Shore-Lesterson, some big names in this, Seth Perlman, have looked at in anesthesia and analgesia. This just came out actually recently, to look at perioperative anemia and to do early diagnosis and try to treat it. And you can see that not everything is iron deficiency, and there are some subsections about how you need to segment out what is causing the anemia. I'll let you read that article. I'm going to go in later into an actual really cool, easy algorithm for how you treat anemia. Not that perfusionists are going to be on the front line treating anemia, but it's out there and people have already done the work, and nobody needs to reinvent the wheel for how to treat the anemia. But there are a number of different iron infusion technologies, pharmaceuticals. And again, I'm not going to spend the time to go into and say which one of these is better than the other, but these iron IV infusions people are fighting in the marketplace for. And I would say the key is a couple of key points. One is how many times you have to infuse somebody to get the iron load in that you need, how fast you can infuse them, and when and if there are any major side effects like a risk of a major allergic reaction. Again, I'm not going to try to endorse one or the other, but your hematologists or your people who are very involved in this can probably, for any given patient, give the best one for a given patient at your particular institution. Most institutions don't have all of them. Most institutions have a couple of them on their formulary, but not all of them. So in that article is a really wonderful review of perioperative blood management. Again, I'm not going to go into it except to say that we in heart surgery really have done a pretty good job, a pretty darn good job of the intraoperative focus. But now it's time, I think, again, perhaps not for perfusion per se, but for the larger group to all come together and say, we need to go push for the preoperative treatment. And then there's the postoperative situation. So why don't we treat anemia? I think it's largely because we're lazy, because we've always said, you know, this is the way we do things, and we've worshipped that we can just simply give a unit of blood and at least get a laboratory value that makes us feel good. But if you look at the chart on the right, you and I take care of some bleeding patients, but even in the worst of situations, bleeding is far less common for us than is preoperative anemia. Preoperative anemia accounts for greater than 40% of why patients get transfused. And so attacking that makes a big, big difference. And then in the ICU, we become vampires. This is how much blood gets taken over numbers of days in the ICU, what happens to people's hemoglobin and hematocrits. And the longer you stay in the ICU, the more likely you are to become anemic. And the number one reason we transfuse people in the ICUs is because of the amount of blood that's been taken out of them. It reminds me of the old MASH movie where somebody ran out of IV fluid and they just hung the Foley back up and used that as IV fluid. So we take the good stuff out and put the bad stuff in and think we're doing a good job. I'll make it relevant to the present day COVID crisis. I've written some editorials in the last few days about the COVID crisis and anemia and just the huge crisis that we're on the edge of with our blood supply. And COVID patients become anemic in the ICU. And they become anemic in the ICU because of the amount of length of time they spend in the ICU and all the blood draws that are coming, plus the profound inflammation that they have at the time. So their erythrogenesis goes way, way down. And we can talk really about some cool biology about that. But so anyway, why do we get anemia? Why do we get anemia and chronic disease? Well, it's rarely for bone marrow failure, certainly rarely for bone marrow failure and heart disease. The chance that you actually have primary bone marrow failure in heart disease patients is fairly slim. Yeah, if we were doing lots of cancer patients, or if we had lots of leukemics or other things, we might be seeing far more of it. But we don't do heart surgery on those that often. Chronic blood loss, GI bleeding, hemolysis, hypersplenism. Again, we don't do that there very often. When do you go and rush to do a new coronary or a new valve on somebody who's GI bleeding? I mean, we avoid that every which way we can. That is disaster waiting to happen. But vitamin deficiencies are very, very common. And if you think about it, the age group that we're dealing with, or the patients who are chronically ill, aren't going to eat regularly. And so if they're not eating regularly, they're not taking in folate, B12, B6, and other special vitamins, and certainly they're not taking in adequate proteins. Even if they are taking that in, they're probably not absorbing it. You get somebody with right heart failure and they have no appetite, clearly, because they're in heart failure. Their gut is inflamed and their gut is not absorbing, and then their liver is not processing all of these key chemicals the right way. So just simply the deficiencies, the intake deficiencies and the lack of absorption deficiencies really play into why many of our patients get anemic. But chronic inflammation, oxidative stress, and overall body inflammation depresses erythropoietin release. Erythropoietin made in the juxtaglomerular apparatus of the kidney is actually very, very sensitive to a protein called HIF-1 alpha. And HIF-1 alpha, people just won the Nobel Prize for that in medicine this year, trying to understand how the body senses oxygen and how that particular single protein plays back into erythropoietin generation. Really very, very cool stuff. But all of that is depressed in chronic inflammation. And so is HIF1 alpha depressed and erythropoietin are depressed. Cytokines actually depress the bone marrow activity. So if you have somebody who's chronically cytokine inflamed, either from systemic atherosclerosis or other mechanisms, that individually depresses bone marrow activity. And we talked about intake of vitamins, but intake of iron and poor appetite and poor ability to absorb things out of the gut is really important. So if you're not eating a steak every day or not eating all your Popeye spinach, you're not getting your iron. And lo and behold, even if you do those things and you got heart failure, you're not absorbing and pinocytosing the iron stores that you need, let alone if your liver's not functioning, you're not putting out ferritin, hepcidin, and all the various wonderful, cool compounds that are needed for the very, very complex mechanism of harvesting iron. The body doesn't like to both take in iron, and it certainly hates to lose iron. We only have a small amount of iron in our body, really a very small amount of iron in our body, even though it's needed not only in hemoglobin, but in all of our cellular mechanisms for making energy and stuff, and it's probably in about 50 different metalloproteins. Whenever we break down iron, it's highly conserved, highly fought over, and brought back to the liver and finds its way back into bone marrow, obviously. So these are all the various different things that trigger and decrease hemoglobin. And just look around there and think, I wonder how many of those my patient has. A lot. And any one of our patients probably has at least 1 to maybe 5 or 10 of those as they come into our operating room. So they got reasons for being that way. And then, as I said, anemia is an independent predictor of so many bad outcomes, and it feeds back into things like heart failure. So there is no doubt that if you are in chronic heart failure and you're anemic, you do worse. But here's the cardiologist's response to that. Give them 2 units of blood. And how many times have I seen somebody go into the cath lab, making sure they got 2 units of blood, and so now they're getting 500 cc's, and yet yesterday they were trying to take 5 liters of fluid off of them. So, sometimes we don't make a whole lot of sense in what we do. But absolutely, if you have poor cardiac output, and you got congestive heart failure, and you got low iron or low oxygen carrying capacity, you're absolutely at a double or triple whammy. So a group of us got together in November of this last year and tried to look at all the world's literature on anemia and do what's called a Rand Delphi study, which is everybody read all the papers, and then independently, each of us was asked certain questions about each one of the papers that we had to answer. And it distilled down after 2 days worth of very rigorous led discussion in a very carefully way done to 5 recommendations. And this paper is now submitted to Annals of Thoracic Surgery. And I have so it hasn't been printed yet, but I got everybody's permission to share these recommendations with you. And the recommendation is we recommend that all patients undergoing cardiac surgery be evaluated for iron deficiency anemia, whether or not anemia is actually present. In other words, if you have a normal hemoglobin, it's not impossible that you are still iron deficient. And that we recommend that the evaluation of iron deficiency includes the following studies. There's some recommendations on there about reticulocyte count, how fast and how much you're making of new red blood cells. We recommend that a patient found to be anemic with iron deficiency should be referred for further evaluation to determine the etiology of the anemia. I'm going to show you that you don't need a hematologist to do that every time. We don't need 2 weeks of workup for every heart patient on this. It can be done by a very, very simple algorithm 95% of the time. We recommend that all cardiac surgery patients identified with preoperative iron deficiency be treated with parenteral or iron. And I'm going to show you some data that you can do that on the operating table. You can do it as we put them to sleep, and that makes a difference. It actually makes a difference before the patient leaves the hospital that they are reticking and that they may reduce their transfusion. And that we recommend that erythropoietin stimulating agents be considered for treatment in a case-by-case basis. Not everybody needs erythropoietin, and that's a real take-home point for everybody, is this is not a call that everybody gets a very highly expensive drug. So what about transfusion? And I'm going to digress for 2 minutes to get on my high horse and get up on my preaching box and tell you that here's the bad news. Transfusion does nothing. Transfusion does not increase oxygen delivery to tissues. As a matter of fact, there are now 9 good studies, and at least 2 of them show, 7 of them show that transfusion does not improve tissue oxygen delivery. 2 of them show that it reduces tissue oxygen delivery. So why do we do it? We do it because it's a simple laboratory value that makes us feel good. It makes us feel good that we did something. It doesn't improve outcome, it makes outcome worse. And the really relevant question, and there are 150 million transfusions given every year around the world, does transfusion do what it's intended to do? Does it improve or prevent adverse outcomes? There are few, if any, articles that support that transfusion actually improves outcome. As a matter of fact, I'd like somebody to show me 10 articles that do that. I can show you 14,000 that show that it makes people worse. So you show me 5 that shows that it does, I'll show you 14,000 that makes them worse. Yet we still genuflect in front of that. And here's data that I've shown many times to all kinds of groups. This is transfusion data at 11 hospitals in Intermountain West, and Hospital A is Hospital A is in outside Seattle in Everett, Washington. Hospital L and K are around Los Angeles, and these are the transfusion utilizations per surgeon and per hospital for routine CABG surgery. And what you find out is that there's a huge variability, and that variability has now been going on for over 30 years. And we have not broken that variability. And lo and behold, the best outcome is in Hospital A that has the lowest transfusion rate. And it's nice for me to be able to say, well, that fits with my model, but it's not science that was done that way. So I can't really call that for what it is. It is interesting, and this is very old data, that those physicians who have the least knowledge about transfusion medicine and about transfusion outcome are the biggest utilizers of transfusion. So those gray-haired old men who are the ones who are demanding that I want all my patients to have thus and so hemoglobin and hematocrit usually score the worst on any transfusion board or study. So I recommend everybody this article, What's Really Dangerous, Anemia or Transfusion? Anemia is very bad, but anemia is only the kicker that makes physicians and perfusionists transfuse when we hit a trigger. And so transfusion actually makes worse outcome 3 times worse than just letting people be anemic to begin with. But as I say, why let somebody get anemic to begin with? Why not treat their anemia before we get them to the operating room? And this is more recent data out of the group, out of the Virginia Quality Initiative in July of 2018, where they looked at exactly that question. And this is for heart surgery. This is anemia coming into heart surgery. And in the upper right-hand corner of the article, you'll see, anemia as a continuous variable, and then mortality. And mortality zooms up when you get really low in terms of your hemoglobin and hematocrit, but it zooms up in response to transfusion. So Western Australia has gotten very, very aggressive about their patient blood management. And in so doing, they've reduced mortality across all hospitals in Western Australia, not just for heart surgery, but for everything. And they've actually saved $142 million a year by getting aggressive. And one of their biggest, most aggressive things is preoperative anemia treatment. I'm just going to move through some of these things fast. because I'm starting to run out of time, I want to give you guys time for questions. So in Virginia did this VCSQI interaction where we got 11 of 16 hospitals to do patient blood management. We studied it, and by reducing transfusions by about a third, we saved a lot of money, and readmissions, postoperative mortality, ventilations all went down. Instead of patients getting worse for less transfusion, they got better. But here's the key. In that, there was no effort to do anemia, pre-treatment of anemia. So imagine what would happen if we did pre-treatment of anemia, which is what the Australian Commission for Safety and Quality in Healthcare has done and pushed all across Australia, is that patient blood management requires that every hospital have an anemia clinic, and that patients coming for elective surgery, all kinds of elective surgery, have preoperative anemia treatment. So here's data from a group in France looking at preoperative iron deficiency in elective cardiac surgery. And lo and behold, they found that in 272 patients, those patients who were anemic had more transfusion. But the key, they didn't show a difference in morbidity or mortality, but they could reduce transfusion. And so what you can say, well, this is kind of a negative study. Aren't we trying to reduce morbidity and mortality? But if you're looking at only 272 patients and they went from 31% transfusion down to 19% transfusion, that's roughly an 11% transfusion rate decrease. 11% transfusion rate decrease across about 130 patients in each one means that only 13 patients had any difference in transfusion rate, and that's not enough for a mortality difference. So it's underpowered to show a mortality difference, but it does show that they could reduce transfusion rate from 31% to 19%. Now, at present in the United States, the standard transfusion rate by STS, all comers for all heart surgery, is about 48 to 50% still today. So this group in France is aggressive about their transfusion reduction, their patient blood management. And so by adding anemia treatment, they can get more aggressive and they can hone their treatment. And so here's what they're finding. Patients with iron deficiency, patients without iron deficiency, how much did they make a difference in treatment? And then Donat Spahn, who's a good friend of mine, who's chief of anesthesia in Zurich, Switzerland, has taken and gotten very aggressive. And this is really cool, is that they look at everybody for iron deficiency anemia, all heart surgery. And if you're iron deficient and you can't go through their anemia clinic, they put you to sleep and they give you an iron infusion while they're giving you your antibiotics. You get it at the same time. And you can say, wow, that's really aggressive. And when I said this to my pharmacy, I got lots of rolled eyes and go, Spiess, you're going to cost us more money. But here's the outcome, is that those patients who got iron at the time of surgery, during the time that they were in hospital by postoperative day 3 to 5, the group that got iron was higher hemoglobin and reticking and got out of the hospital with a higher hemoglobin rate. Now, they haven't been able to show that they've got a reduction in morbidity or mortality, but it wasn't powered to do that. All it was powered to do was to say, if we give you iron, do we see an effect while you're still in the hospital? Is it worth it all to give you something? So how many times do I hear from our people, well, I can do whatever I want, but as soon as I discharge the patient, the local MD, the local cardiologist the patient goes back to is going to give them a unit of blood. Well, maybe I can affect this in the patient's best interest by treating them in the future. And this actually had a wonderful, nice editorial with it, editorial comment with it that really said, hey, this is something for us all to look at. But I dare any one of us in our hospitals in the United States to go to our hospital pharmacies and say, now I'm going to add another $400 worth of pharmacy charges on because I'm going to do this based on one paper. Not going to take it so far. And here, this is hot off the press. It's not even published yet, but it's been accepted and I've been allowed to have it. So this is that Jehovah's Witnesses for heart surgery, it makes a difference to treat them. And so if we treat Jehovah's Witnesses by treating their anemia, delaying their surgery and treating their anemia, they do better, they get less blood, and they're discharged in a shorter period of time. And this is my challenge to every one of us, sitting in the audience with your feet up, having a beer, listening to me at home, is it now unethical to treat Jehovah's Witness patients better than to treat the general public? You know, we used to say, well, we'll do everything for a Jehovah's Witness. Well, if I come for heart surgery, I think I just changed my religion. I think I need to be a Jehovah's Witness. I think I need to walk through the door and say, I'm a Jehovah's Witness. Don't you dare do anything that you wouldn't do for Jehovah's Witness to me. You better give me the same kind of surgery with closing my chest dry rather than the sloppy way you do it for everybody else. You better get surgery done half an hour to 40 minutes faster for me, and you better have the lead surgeon doing it rather than the med student closing me. And so it is absolutely unethical, as far as I'm concerned, to treat one group of patients different than another. And so we gotta come around to that. So which intravenous preparation do you use? Once again, I don't really know, but clinical cost effectiveness, and this is, again, I think a French study, but they found that it saves about 800 euros by treating patients for their anemia prior to heart surgery or prior to elective surgery. It saves 800 euros per hospitalization to treat the anemia. Wow, that makes a lot of sense. So there's lots more data about blood conservation. This is stuff out of Inglewood Hospital. Most of us know this. Those patients who get patient blood management do better, save a lot of money. This is data out of China. There's a place that now does 3,500 heart surgeries a year in China, Fuwei Hospital, and they're seeing a radical drop in their utilization of transfusion. And those patients who have patient blood management because they've adopted it, damn it all, if China can adopt it, why can't we? Why can't we, as we're still only 35% of our hospitals, and 35% of cardiac surgery hospitals are doing anything to do with this? And so this is the Western Washington program. They're in not Western Washington, Western Australia program, 41% reduction in red blood cells as they instituted their program in heart surgery. They reduced transfusion by 41%. Blood acquisition costs way down, estimated cost savings, improved outcomes, did everything together. So here's what I told you I would show you. This is the algorithm. I'll make all these slides available through this meeting. Anybody can have a copy of that algorithm, but you can also get it in 2 seconds on the internet. If you go down to that thing at the bottom, it's called the OnTrack program. OnTrack stands for Ontario Transfusion Program. And so the province of Australia, the province of Ontario in Canada, has got a program where every hospital does preoperative anemia, and this is the treatment algorithm and the way they work through their patients. And it's all published and it's out there. Just go to ontrackprogram.com, look up anemia treatment and management, and it's right there. You know, you don't need to reinvent the wheel. So you don't need a hematologist. You don't need an MD degree and 4 extra years of training to figure this out. It's pretty damn simple. So a new paradigm is anemia is an independent risk for morbidity and mortality, regardless of the level of hemoglobin, and transfusion makes it worse. That's my 2 cents. And there are other papers coming out about how anesthesiologists need to lead that role, because now we're involved in all of perioperative care. And so I'm going to open it up for discussion. And I think eventually I would like us all to think about which patients could we postpone their next day heart surgery for a week or 10 days. And this is what I asked our surgeons. Which patients can you postpone for 2 weeks? And can you have an intelligent discussion with your patient and say, I know you'll do better if you can wait 2 weeks. And I know you're not crashing, and you can't do this with unstable angina, but you can do it with somebody who's got stable but worsening heart failure from a bad aortic valve or a mitral or something. And you can do it for people who have slowly worsening aortic aneurysms. There are many of our patients. I would bet you there are 60% of our patients that we could do this with if we put our minds to it. And I'll stop there, and you guys can turn up the mics, and I'll take any questions you have.